So the title of the presentation, of course, is the role of the Therapeutic Alliance in short-term psychotherapy. People don't know this, but I was in psychoanalytic training when I first came to San Diego, in the San Diego Psychoanalytic Institute. And one of my supervisors was a very, very famous psychoanalyst from Menninger's, and he told us the perfect analysis was the patient walks into the analytic therapy on day 1, lies down on the couch, begins to free associate, and leaves 5 years later, and the analyst has never said a word. I don't know if that would be a good example of a therapeutic alliance, but that was this supervisor's idea of the Therapeutic Alliance. So the title of this talk, it really is, Kristin, it's all about the Therapeutic Alliance. And that's why Kristin asked me to come speak.
Fantastic.
Oh, you like that, do you?
I love it, Rob. Can you do it one more time with feeling?
Just wait. We'll have many opportunities. So in contrast to my supervisor in the Psychoanalytic Institute, what I would say is the Therapeutic Alliance begins when you express to the patient, what would you like me to help you with? There's many ways to say this. You can say, what problems are you dealing with that we should address? What brings you here to see me? You know, you can ask it so many different ways that's in your style, but that's the initiation of the relationship as you're extending your hand, right, to the person to offer to be of service to them and give them the benefits of your professional expertise. You're not a rent-a-friend, you know, has been accused of some psychotherapy skeptics have said. You're there to set with the patient what are the therapeutic goals. It is a goal-directed therapy. Now, again, on the far extreme of psychoanalysis, some psychoanalysts would argue against that. They would say that setting up that goal-directed model is counterproductive to real exploration of the transference and creates an authoritarian transference immediately. So, you know, like all things in life, you're damned if you do, you're damned if you don't. Every intervention has a price. Every intervention you don't do has a price, okay? You also define the tasks that make up therapy. This has been referred to, and we'll go into more detail about the working alliance. What's the responsibility of the psychotherapist, and what's the responsibility of the patient? You know, it's a very, very important component. And then finally, last but not least, the bond between therapist and client. And I'll make some comments about that, some unpublished research. Some of you may know Sue Ann Pilero. Sue Ann was a graduate student working with Diana Fosha, and she did a study of my work versus Diana Fosha's work. And it had some very interesting results that I don't ever think got published, but I wish they did. But we'll talk about that. So, types of therapeutic alliance, the working alliance, which I just defined, the tasks, the therapeutic alliance, which is non-specific. It has the working alliance as well as the bond between the patient and the therapist. So Sue Ann asked if she could study outcome of 10 patients of mine that did really well and 10 patients of Diana Fosha's who did really well in outcome, and could she interview those patients and send them questionnaires. This was part of her graduate study, and she sent those out to um, the the patients, and she did a really good job. I thought it was a really well constructed study, and she used a number of parameters, and the striking difference was the degree of positive feelings that the patients had towards Diana Fosha, as opposed to the feelings the patients had towards me. They looked at me as an ally, a reliable friend who helped them accomplish what they wanted to accomplish, but they did not have the deep warm and fuzzies towards me that they expressed towards Diana Fosha. There was absolutely no difference in outcome in these two matched groups of patients. And I think 10 patients is enough to achieve statistical significance. So my conclusion for that is that the warm fuzzies are a non-specific factor in psychotherapy, that they can be there or not be there, but they're not necessary for outcome, for positive outcome. Another specific factor that people talk about is the unconscious therapeutic alliance. Now, this is something that is specifically related to Davinlo, okay, and his model of therapy. He came up with the idea, and we can talk a little bit more about what that really actually represents. Kristin, are we going okay? Are we staying on topic for it's about the Therapeutic Alliance?
Yeah, we're definitely on topic. Absolutely. And I mean, I think, Rob, it's like you're so when you were bringing up warm fuzzies, what's happening for me inside is that we're really paying attention to how important it is to attune to a person. And that attunement can come in different ways.
Different ways. Attunement is essential, but it doesn't have to be in necessarily creating a positive mirror for that person.
No.
And carrying that to an extreme. That's not one of the key curative factors of psychotherapy or dynamic psychotherapy, in my view.
Great point.
So we know that the Therapeutic Alliance is critical to successful therapy. We all agree on that, don't we? Any dissenters? If there are, press the buzzer. Kristin will give you a refund. Beyond that, however, we seem to have a notable divergence in how we understand the alliance and why it's important. So let's look at what science has to say about it. This guy, Edward S. Bourdin, I don't know much about him, but he was the first guy who identified the working alliance. He called it a collaboration for change. He actually used it as a model for supervision when he would supervise his students. Mutual agreements and understanding regarding the goals sought in the change process, what the tasks are of each of the partners, and of course the bond between the partners necessary to sustain the process. But the headline that the alliance appears to contribute more to therapy outcome than almost every other factor that has been rigorously researched, save for two: empathy and goal consensus collaboration. The meta-analysis by Horvath in 2011 found a huge effect size, moderately but highly reliable relationship between alliance and psychotherapy outcome. The alliance counts for 7 times more of the variance in outcome than other therapy models. Okay, so that, emphasis. Josette and I, over the years, have emphasized when the patient returns to the session following your previous session to review what stands out for the patient from that previous session, as opposed to, in addition to what the patient wants to work on in the current session. So we're always boosting and supporting the working alliance. One thing that's really important to realize in the research, the relationship between alliance and outcome is bidirectional. The alliance predicts outcome over and above the effect of prior symptom improvement, supporting a reciprocal influence of the relationship between alliance and symptom change. So the patient's symptoms of depression, anxiety, somatization, self-defeating behavior, okay, directly correlate with increases in the strength of the therapeutic alliance. Okay, so it's bidirectional. The less symptomatic the patient is, the higher the therapeutic alliance. The higher the therapeutic alliance, the less amount of symptoms the patient is suffering from. Okay. So that's, two really good pieces of research. Now, the third one that is of great interest to Kristin and the ATP group, as well as the STDP, ISTDP community, is how important is affect experiencing to outcome. Okay. Kristin sent me this paper to review and add to the study by doctors Alvernaise, Bergaff,
yeah,
and Hoffert, Stills, Svartberg, McCullough, and Wampold. It depends on the approach. Apparently, it's important in STDP and ISTDP in that cultural group, but in CBT, it's not that important outcome. The therapeutic bond as a component of the alliance is a common factor, okay? However, the relationship between therapist action, bond, symptom reduction differed for the two treatments. For STDP, avoidance of affect or suppression interfered with symptom reduction. In cognitive therapy, avoidance of affect was positively relation to formation of the bond and to symptom reduction. Although the bond is a common factor, an important component in the alliance, it operates differently. So a focus on affect is important to the benefits of STDP, ISTDP, but can interfere with the benefits of cognitive therapy. Now that's this research paper. That's only this one paper's results. Now, Leigh McCullough was the exception to that rule, interestingly. Leigh and I were at a conference together presenting. So Leigh comes back from the conference, just got off the airplane, and she said, I just finished the results of this paper. And when I did a microanalysis, I found, and I broke down by therapists, the certain CBT therapists who worked with outcome got better results than the therapists who didn't work with affect. So Leigh's opinion was a little bit different than that was published in the previous paper. Okay, so she found the highest rate of success in CBT group focused a great deal on the experience of feelings and emotion. Okay, that's the subgroup within the CBT group that was reported in the prior paper. A little bit of contradictory information. There's been lots of research efforts into outcome. Alexander and French, David Malan, Davenlo, Winston, and the Beth Israel group, Alan Abbas, Leigh McCullough, and a host of Norwegian researchers. Alexander and French found no relationship between length of treatment. Remember, in the 30s, psychoanalysis was the gold standard of treatment, and their research showed twice a week psychotherapy was equally, if not superior in outcome. They believed there was sound use of principles needed and required more training, not less training, on part of the therapist to get positive outcome. Re-experiencing the old unsettled conflict, but with a new ending. Doesn't that sound nice? Isn't that great?
It's lovely.
It's the secret of every penetrating therapeutic result. This is Alexander and French. Of course, Franz Alexander went on from there to found the Southern California Psychoanalytic Institute, left Chicago, and continued to practice formal psychoanalysis. David Malan's research from Tavistock, most dramatic results in STDP achieved with patients who had chronic, long-standing difficulties. Essential factors included the therapist's ability to view the current difficulties as the most recent example of core conflicts that originated in the past. Here we go. The therapist is able to identify transferring pattern of behavior and deal actively with negative transference as soon as it shows up. The patient has an emotionally meaningful response to interpretations linking the past and the present within the first 4 sessions. Those are called TCP interpretations. Davanlu did 638 patients, all recorded on videotape. He demonstrated it's possible to expose those core conflicts within the first contact. Not only that, he felt it was essential. He believed the emotional and visceral experience of feelings was the specific key to cure. And he developed techniques to create an intrapsychic crisis, creating a therapeutic emergency, allowing for rapid reorganization of personality. Long-term follow-up revealed sustained nature's changes. According to personal communication from David Malan, that study of over 600 patients had about a 70% improvement rate and very a commensurately low relapse rate. Not cure, but sustained improvement over time. Beth Israel group, when Leigh and I were in training together, were the ones who were looking at the ISTDP group. What's really important about this slide is that these were not Davanlu doing these treatments, and there was a large and high dropout rate of patients. So the patients who remained in therapy, it was effective, but a lot of people couldn't tolerate or didn't want to tolerate the treatment. We've already talked about Davanlu's ISTDP. I'll skip over that. I will say it's based upon the psychoanalytic model of id, ego, superego, which is called the structural model. And that has been translated into what we call the triangle of conflict. Superimposed on that is conscious, preconscious, unconscious. And each segments of the id, superego and ego, at least the superego and the ego, have both conscious and unconscious components to it. Mentioned the 2 triangles. Here you've got those. It's broken up into formal defenses. These are the repressive defenses that are worked with in that triangle of conflict. And these are the regressive: projection, denial, dissociation, acting out, and somatization. The tactical defenses: verbal. Davanlu was the first, I would say, Fritz Perls and Davanlu would have been the ones who have did the most to describe tactical defenses, right? These are interpersonal defenses used to create distance and sabotage emotional closeness. So the system of ISTDP: love and attachment, pain and grief, anger, rage, guilt, and resistance against emotional closeness. I called that the PASO. Okay, it's a resistance-based system. And again, this is Davanlu and Malan. There was a big in the 60s and 70s a research effort. What are the specific factors that are unique about one form of psychotherapy versus the other? And the actual experience of true feelings about the present and the past was seen as the specific factor, okay? And affect phobia therapy is a direct descendant of this observation. The sister therapy that doesn't get enough credit is emotional focused therapy. If you watch Leanne Campbell and Sue Johnson and their group, they're really experts at working at the defenses against emotional feeling and connection and attachment in a caretaking and caregiving relationship. Okay, so EFT doesn't have, as far as I know, direct lineage back to Davenlu, but Diana Fosha was a student of Davenlu's. Leigh McCullough was a student of Davenlu's. Mike Alpert, myself, you know, Davenlu really brought the experience of feeling and emotion in the here and now, in the transference, as being the specific qualitative curative experience. Obviously, in order to create that, you have to have a very strong working alliance. So the whole idea is, let's expose the core neurotic conflicts. If you have guilt over murderous rage towards your caregiver and you're sabotaging relationships between that, you need to take a hard look and experience that murderous rage and forgive oneself rather than punish oneself. Okay, but there's resistance to change. Freud in his writing wrote over and over again, the neurotic patient suffers. He does not know he's guilty. He is dumb, meaning inarticulate about the fact that he is guilty. All he knows is, or she knows, that they're suffering. So the unconscious guilt drives the suffering, and the working alliance, okay, leads eventually to the development of the unconscious therapeutic alliance. Okay, so after the intrapsychic crisis, after the breakthrough of rage, guilt, grief, love, okay, right, the working alliance is strong enough to defeat the resistance. The unconscious therapeutic alliance in Davenlu's system is created or born over the defeat of the resistance. The collapse of the resistance creates a new state of mind called the unconscious therapeutic alliance. He called it a healing force within the patient. Now that got a little too mystical in a way for my taste. And I thought, in the way I reframe that, it's the inherent desire in all of us genetically, okay, for secure attachment. We all desire to be joined with the other person, as Kristin said, in that state of attunement, that state of reciprocity, where the ebb and flow of your completely disgusting emotions and completely unconscionable impulses are accepted by the other person with love, compassion, and empathy. That's an inherent unconscious longing that we have. So with that in mind, it then means that your pre-existing attachment traumas are magnets that are you're pulled towards, as opposed to powerful forces that you're fighting against. There's a shift in the organization of the unconscious towards the core traumas, and it's mobilized by that defeat of the resistances. Okay, I hope that's clear to everyone. So, Kristin, I think I'm on time. I think it's about a half hour. I'd like to summarize. I'd like you to read the following, please.
Okay. Kristin, it's all about the Therapeutic Alliance.
Kristin, it's all about the Therapeutic Alliance. So when you're looking at that domain of the ISTDPs, attachment-based, ISTDP, any other modification where you're exploring the unconscious, okay, It's about the Therapeutic Alliance as the tool to overcome the forces of resistance, which are designed to sustain the patient's suffering. They get short-term gain, meaning their anxiety is alleviated, okay? Their unconscious guilt is mitigated, okay? But their suffering continues. That's the concept of neurosis. And these are the list of the references that were given during the presentation.
Well, Rob, I don't know if you were aware of saying this, but what I heard was that acceptance, like within the working alliance, is what, you know, cultivates like a strong therapeutic alliance.
Those are the components.
Mhm.
The working alliance is the component to build the dominance of the therapeutic alliance over the forces of resistance. Okay? And then at a certain point, there's a shift in the balance, and at least in ISTDP, the unconscious working alliance takes over, and that's the force that drives the therapy to termination.
So when you're working with someone and you're sitting across from them, like what is guiding you? I certainly accepting what they're experiencing in the moment with you is one thing that I'm hearing. But what else guides you when you're in session with someone?
Curiosity. Okay, 100%. It's an attitude. Again, if you do the studies in securely attached kids are incredibly curious about how the world works and why. So what is underneath this current degree of symptoms that you're experiencing? I'm really curious and interested to understand the desire to seek information, put pieces of a puzzle together, and develop a therapeutic understanding of why you're feeling the way you're feeling, particularly because you don't want to feel that way. You know, the alliance, every word I speak comes from the alliance. You don't want to feel that way. That's why you're here. Does it make sense what I'm saying? So it's a attitude of inquiry. We're inquiring into the nature of your symptoms, the context of your symptoms, the duration of your symptoms, and what is it that makes your symptoms rise, and what is it that makes your symptoms abate.
So really, like, having an understanding about the symptoms is a really important part of the working alliance. Just
yes, and instilling that in the mind of the patient.
So helping them increase awareness of what is happening for them and what it's about is really important.
Totally.
Yeah. I mean, one thing that I've seen in your video segments that you've shown is you are very good just over and over and over again helping people understand why they are symptomatic, where it comes from, and how they want to change that. And so, you know, from an APT perspective, it's core conflict formulation. And that's one technique that I see you doing a lot when you're working.
As well as an ISTDP formulation. They're both on the same page. Yes.
Yeah. Wow. Well, I'm curious to see if anyone has any questions that they'd like to ask Dr. Neborsky.
I have a question.
Yes, hi.
Hi, thank you. This is amazing. Your presentation, you packed in so much, 30 minutes. I'm not quite sure how to articulate this. When I started teaching, one of the most helpful pieces of information I got was somebody explained that female faculty tend to get positive student reviews if they behave in gender stereotypical ways, and less positive reviews if they aren't stereotypically feminine or female in their, you know, like show expressions of caring for students and all of that. And so I just was curious whether in the research you mentioned earlier about how important the warm fuzzy feelings towards the therapist are, if anybody's looked at breaking that down or through by gender.
That would be a great study. And I'm sure it wasn't, since I was male and then obviously Diana's female. So I don't know, but that's a, you know, just a fascinating question. You know, I will comment that Davinlu's analyst was a woman, and she used to take phone calls during his therapy sessions, and that would throw him into complete tizzy. You know, that's where he discovered murderous rage when he discovered it, because she wasn't giving him her undivided attention. You know, now, you know, we could say, you know, she was behaving in a gender atypical way, and that, you know, for a Middle Eastern man can sometimes rub them the wrong way. Yeah.
Really interesting question, Lisa.
Yeah, isn't it?
Yeah. Now that's worth another therapist hour right there. I'm writing it down right now.
I have a question.
Hello.
Can I ask a question?
Yes, yes, of course.
Thank you very much, Dr. Neborsky, for your very interesting presentation. I have a question about the beginning, where you spell out different elements of the Therapeutic Alliance, the therapeutic goals, therapeutic tasks. And I wonder, do you spell out the tasks and the goals in the beginning phase of a treatment, or does this remain implicit during the first?
You know, thank you for that question. That's a really important. I would say that I do it more intuitively with different patients. Some patients I need to be more explicit with, particularly the patients with regressive defenses. Okay, they weepy, dissociative, helpless, escape artists. You know, I have to make a very vivid paintbrush to be aware of those defenses when they emerge, and, you know, put our foot down that we don't go there. Okay, we're learning to tolerate anxiety, and we're learning to build ego adaptive capacity. The patients with the more formal defensive structures, I'm more likely to use pressure and challenge with those patients and not make it as explicit, because they get it, you know, pretty quickly. So I would, I wouldn't say one suit fits all. I would say I modify it according to the clinical presentation that I see during the initial assessment. But to some degree, it's all there, one way or the other. And remember, the three components is also the bond. Let's not forget that the bond, which is in the transference, both positive and negative. Remember, transference has both components to it. You know, these patients' parents weren't all bad, you know, and they did a lot of really good things for them, and those expectations are transferred to you, as well as the expectations of the negative responses and actions.
Thank you for this answer.
Yeah.
And Dr. Neborsky, I'm really like how you're emphasizing the positive and the negative, because it's very true. Like in a healthy relationship with another human being, having the capacity to experience all feelings is an important aspect of that. And And when you're doing therapy, you know, being accepting of all the feelings that come up during the psychotherapy experience. And I think for us therapists, being able to hold the negative and the positive is really important. And it sounds a lot easier than it is to do.
Yeah, I mean, that's why we're having these conferences all the time, because it's certainly not an easy task. It's as complex of a task as there is on the planet.
Right, right.
I have a question. Should I go?
Yeah.
So somebody at EDT list had asked this question. What's the difference between ISTDP, AB-ISTDP, DEFT, and AEDP? And how does ISTDP work with Asian population? So what I was thinking when that question was asked, I was thinking that the melt, you know, two polarities, the melting defenses and challenging defenses. It sounds like in the melting defenses camp is more Susan Johnson and AEDP and DEFT, and that ISTDP, AB ISTDP seems like more towards challenging defenses. So in the challenging defenses, it seems like you are able to facilitate negative transference. You know, so the AB ISTDP and ISTDP seem to, the therapists on that camp seems like they're more able to tolerate negative transference, because when you challenge defenses rather than melt defenses, the clients are going to have more of that negative transference than positive transference, right? I mean, so that's what I wanted to ask. Or the right brain and the left brain, it seems like AEDP, there's a relationship between right brain and right brain. That's what you try to go for. And then in ISTDP, it seems more, I would say, masculine, more the left side, you know, more the left brain neocortex abilities, right? So what what I'm saying is that, does that apply to AB ISTDP? I mean, do you see that?
Let me just, yeah,
Sure.
I can't comment on all therapies because I'm not an expert on all therapies. I can comment on Davinlu's ISTDP
Okay.
since I was trained by him. And there's not one Davinlu, by the way. There's 3 Davinlus. There's early Davinlu, where he was experimenting with his model. Then there was phase 2 Davinlu, where he was inventing the graded approach. And then there's phase 3, where he went back to heavy doses of challenge and pressure in the transference, and that being the royal road to the unconscious. So he zigged and he zagged in his historical approach and invention, and settled down in that last approach where there was an insistence on a breakthrough of the negative transference in the first meeting. When I went through training, we didn't do it that way. We went through current life situation, past events, or transference, wherever the patient seemed to take us. We planted our flag. And I continue to do it that way, the way in which I was trained. I haven't gone over to the that different model that he currently teaches. That's point number 1. What is attachment-based ISTDP and the difference? Josette and I put a very strong emphasis on identifying the eyes of the superego. The superego pathology of the patient is an internal object relationship that contains the original attachment trauma. And the patient's allegiance is to submission or defiance of the commands of that internalized object. So we do our best to get the patient to recognize that their defenses are an act of subordination to that internalized object relationship. And we do our best to break that bond, that pathological attachment bond, and create a new world order. Okay. The new world order is, treating one's feelings and internal experience with love, care, and precision. Love, care, and precision. Until you're sick and tired of hearing those words, love, care, and precision. We're going to look at your experience through new lenses. Okay. So have the old attachment model, the new attachment model. Pick which one you like better. If you like that old one better, and you want to stick with that one, God love you, and I'll pray for you. Okay. All right. But if you want to try with this new model, I'll do my best to side by side with you, to model that form of conduct and how to implement it in your inner life and your waking life.
And when you see Dr. Neborsky's video segments, like one thing that's so interesting about his work is that he can both be challenging and melting with the same patient in the same session. And so sometimes you'll see him challenging and sometimes you'll see him melting. And so there is this real kind of right brain, left brain feeling that you were describing. And, and as I was just listening to him right now, I guess he's offering his patients the opportunity to release themselves from the trauma bond that was developed in childhood. Like it's an opportunity to do something different. And I've always loved watching how you can shift from a challenging position to a very loving and kind position. And I've seen the same thing in Josette's work too. So
is that after you challenge first that you move to melting, or do you ever start with melting and go to challenge?
Geez, that's a tough one for me to answer. I have a specific approach that I use for every patient who comes in. And that's to begin establishing the working alliance that we're working together. And as we're going through the process, the patient is going to create their defenses. I was working with a therapist the other day who is complaining of narcissistic abuse from her husband. And then first thing she does is begin putting this big engaging smile towards me while she's telling me about, some pretty painful experiences that she's having. Okay. So what do I do? I mean, it's right there. I point out to her the discordance between the smile and the content. Okay. So what does that tell? That tells me she's caretaking me in the transfer. She's not wanting to dysregulate me, and that she's got an insecure avoidant attachment style. Okay. So I'm going to keep pedal to the metal. I'm not going to let her do that. Each time she does that, I'm going to point out to her, she's again putting my feelings and how I'm going to react to what she's telling me ahead of what's in her own best interest. And I give her the choice. Does she want to do that? Now, anyone who's in their right mind is going to say, no, I don't want to do that. So then you got your foot in the door, and actually this was an interesting moment. She's an EFT therapist herself. So we were off to the races immediately. So I was very firm with her. She's using a tactical defense that was extremely counterproductive to her therapeutic goal, which was to get in touch with her true feelings about her husband in her marriage and what she needs to do in this relationship.
And so it's just another reminder as we wrap up for today, Dr. Neborsky, that, you know, being able to see someone's defenses and to articulate it out loud to them can be one of the most loving acts of kindness that you can do. And you know, when you're working with people who have been well defended over the years, to be seen, it is to feel cared for and loved, even if it's hard, and you know, and it can bring up like anxiety and resistance. And that's something that I think you're expert at, Dr. Neborsky, is really seeing people and being able to mirror back to them what you see, and then ask them if they want to do things differently. So.
Thank you, Kristin. I hope that's true. It's my aspiration.